My next topic is I'll talk about injections, diagnostic and intervention. Although you'll quickly learn these injections being diagnostic. No conflicts to disclose. So we as dentists, we're good at injections in the mouth and I would argue even on the face. Okay. Why do we use them? For, of course, diagnostic reasons, therapeutic reasons, and especially lately, I've had this question from a bunch of my residents, even at students, could they be of prognostic value? So if you inject local anesthetics and they respond, can you inject Botox or steroid or something stronger? And there's really no data, so we're not going to talk about it, but it's that's the one thing I like about kind of teaching. I get to know what I don't know, so it is kind of very important in clinical practice. All right, so diagnostic injections, concept-wise, it makes sense. You numb an area, if it gets better, it's diagnosis. But practically, our system is quite complex. Just because you numb a tooth and the pain goes away doesn't mean the pathology lies in the tooth. Because our nervous system is neuroplastic in nature, and then on the other hand, there is cascade of events from a dental structure or a part of the masticatory system to the trigeminal system. There's a lot of interrelations. So in practical terms, it really does, it's not as simple, okay? So in dentistry or even, and I spent a fair amount of time looking up literature, and there's really no data on diagnostic value of injections. Okay, but when you look at pain literature, there's a fair amount of papers that I found which talked about why it's a problem to to look at these injections at diagnostic, and I'm really thinking of local anesthetic injections. You could have a placebo response, you could have a bias, especially expectation bias. So if I'm getting an injection, my expectations are, oh, I'm getting an injection, so you have a little bit of a stronger placebo response. And then the anesthetic can definitely spread to other areas. Some people inject a lot. I tend to inject a very little amount, and we'll talk about that. And then just because things change doesn't mean you are kind of targeting the mechanism. And then the biggest thing is you do an injection and you have pain relief. I'm looking for pain relief for 2 to 4 weeks after doing lidocaine or bupivacaine. How do you explain that? Okay, so those are the kind of issues with thinking of local anesthetic injections and diagnostic, and some of those issues even are inherent when we're using it for as diagnosis of endodontics or the lack of. So it's not okay. So I'll stick to some of the commonly used injections that evidence exists to some degree. Local anesthetics are the most common agents that we are using nowadays. Corticosteroids, we use it a little bit. Botulinum toxin is definitely getting more press. And then there's other agents which I often use when I kind of hit a wall. The data is really unclear if they work better. They work quite well in my. So a little bit about mechanism. What do the injections do? And I, again, think it's sensory tricking. And the sensory tricking, interestingly, is beyond the anesthetic agent. this, because you numb the area, it becomes numb, so the brain understands that the perception is different or stops, the pain perception stops. And then even though the numbness wears off, the brain kind of re-educates. And I think the brain almost gets a break, which it hasn't. And that 2 hours of brain is really powerful. So in the 70s, they talked about breaking the pain cycle, which I think is similar to sensory tricking, change in neuroplasticity of the nervous system. At least functional imaging studies show that it happens with anti-epileptics. Doesn't really happen with injections. It's possible, though. And local anesthetics, as well as corticosteroids, have a profound anti-inflammatory effect. Not a profound. Corticosteroids have a profound anti-inflammatory effect. Local anesthetics have some anti-inflammatory effects. So, and a few studies have even alluded to it being an acupuncture-like effect. Okay, although, like just we mentioned during the previous question answers, we don't know what it means. Okay, so what do I inject? This is kind of my cheat sheet. And just email me if you need slides, happy to share them. So most commonly I use lidocaine, bupivacaine, and then uncommonly I use the other agents. So kind of, but when it comes to joint, I often do corticosteroids. Okay. So before we talk about different agents, we're talking about non-specific temporomandibular disorders. Okay. You have to do your due diligence, make sure you're not missing a red flag, make sure you have your diagnostic, differential diagnostic in kind of mind. If it's an internal derangement and you do an injection, it may or may, it could work, but more likely it's not going to work. So you got to be somewhat confident about your diagnosis that it's temporomandibular disorders. Okay. This paper looked at trigger point injections, and they compared dry needling to lidocaine to bupivacaine, and they found very similar outcomes in these kind of population. And it was a small study. They had a follow-up of 3 months. Sorry, I should have made a table, but they compared botulinum toxin to dry needling to 0.25% lidocaine. Okay. And so not really much to choose between the three. Okay. And that's been repeated number of times. Okay. So, and with similar results. And they've looked at corticosteroids versus lidocaine, botulinum toxin versus corticosteroids, very similar results. And when I say similar results, short term, 2 to 3 days to 30 days to 120 days, extremely similar outcomes. There's, at least to my knowledge, there's like 2 studies which show that botulinum toxin works a little better at 180 days. So just 1 injection in masseter has a little bit improved impact at 6-month follow-up. So they're all good agents. Okay. So this systematic review looked at 12 randomized clinical trials, and they found that botulinum toxin was definitely more effective than placebo. Okay. Again, not a lot of studies. Okay. And at 3 months and 6 months, it's botulinum toxin was similar to different injections. Okay. And then, of course, it was better than some other treatments like low-level laser therapy. But they don't talk about if patients had very diffuse pain or localized pain. And most of these studies have very small numbers. Okay, and all right, switching to corticosteroids. Okay, we have number of agents available to inject. I tend to be very conservative when it comes to corticosteroids, and I happen to use them a lot. And again, I have had a number of patients with side effects. Okay, so I feel corticosteroids are stronger agents, very effective agents, but slightly more risk of side effects. So if you're injecting a muscle, stick to dexamethasone because it's a non-particulate corticosteroid, so your risk of neurological side effects is low, bleeding is low. There's definitely data that if you inject triamcinolone or prednisone in a muscle, you can really get in trouble, especially because there's like irreversible neurological changes associated with particulate corticosteroids. Although when it comes to the temporomandibular joint, there's more data that triamcinolone works quite well. It has a faster onset of action. So when it comes to the jaw joint, I use triamcinolone. While it comes to muscles, I typically use dexamethasone. Some of the studies have looked at 0.5 to 0.75 milligrams of dexamethasone. I typically use 0.25. I would say in the last 4 weeks, I've probably injected about 7 to 10 patients, all of them 0.25, 0.3. So extremely low dose, and it works quite well. And when I say it works quite well, I'm looking at 30-day improved pain in my practice. I always tell patients what it does in the next day or so has no meaning. It's a spa effect. You feel better or you feel worse. If you feel worse, it's the trauma from needle. If you feel better, it could be just a relaxation effect. What happens in the next 4 weeks is meaningful. So, talk about local anesthetics. I use them a lot more than corticosteroids or botulinum toxin in my practice because they're very forgiving. They're great agents to use. There's very little systemic toxicity, especially in the doses that we use for temporomandibular disorders. Yeah. And even if you inject a vessel, okay, as far as you're using low doses, you're not going to have systemic toxicity. I have, in my career, thankfully, never had a problem with actually, I'll talk about that, except one patient never had issues with local anesthetic trigger point injections. And I do probably 15, 20 a week. So I use them quite commonly. The one patient we had, this was at the residency program where I teach, had this patient, did trigger point injection. She felt great for a month. We did plain carbocan. Second time, comes back after 1 to 2 months, do carbocan, and she has like anaphylactic-like reaction. So that's what the ER, we had to send her to ER because she started having trouble breathing. And luckily we were at the hospital, so it was quick. And she was kept in the hospital for a day. They said it was anaphylaxis. I'm like, it doesn't make sense. The first time she had no problem with carbocan. So, and often at times I use topical preparations using different anesthetics. We're not going to talk much about that in this talk, but there's value. Okay. Again, diagnosis is very important before you talk about treatment. I'm not going to bore you with the complex diagnostic kind of paradigms. I'm going to make it simple. So, patient comes in, in my kind of simplistic model, they have acute pain, they have chronic pain, and then they have this acute flare-up of a chronic pain. Okay. When it comes to acute therapy, local anesthetics are great. When it comes to acute flare-ups of kind of this chronic problem, they're great. But when it comes to chronic therapy, confirm the diagnosis. Think what else is involved. Is it a sleep problem? Like I said during my appliance talk, a lot of patients have sleep disorders, and those patients, I find, they just don't respond to injections as a first step. I tend to do it as a second, third step if they need to. Okay? So I'll make a case of using less rather than more. There's some data, it's not conclusively. Most studies have looked at very significant amount of local anesthetics. Some studies have looked at if you put in, say, 0.3 ml of lidocaine or 0.3 ml of bupivacaine, you will have a much more profound sensory block, but you won't have as much of a motor block. So using less, so the patient may not feel numb, but the analgesic effect would be quite good, and it may have a much better effect on the pain kind of mechanism compared to using a higher dose. I typically do, so if it was a painful masseter, I do 0.2 ml, but I do 3, 4, 5 small areas in the masseter. Typically 3, but if it's a really big muscle, 4, 5 areas. So I often do, and the reason why I do that is I'm kind of thinking, if it was an acupuncture-like effect, I want to kind of inject, because as you are all familiar, botulinum toxin involves number of these needling. Is it that, or is it really the... So, and then a few months ago, I found this paper where it found that one of the most often needles, the feeling of numbness is what people really dislike. Reason why people often are afraid of dentists, and that includes us. So when they have significant numbness, there is a significant amount of anxiety and unpleasantness. Yeah. And there is some argument that's been made that once the numbness wears off, you could have rebound pain, because it just comes back with a vengeance. That's kind of, although hasn't really been shown in kind of clinical trials. When do kind of these trigger point injections fail? Okay, so when patients are apprehensive. Okay, so then often. And a lot of times they fail the first time, but then the second, third time they don't fail. Okay? When they're afraid, so often at times I would say don't do a trigger point injection during the first visit, do it second or third visit. Tell the patient, let's try this, and if it doesn't work, maybe we'll do a trigger point injection, we'll put a small amount of anesthetic. What if the pain is diffuse and unexplained? Then it's not the right modality. Somebody who has extreme fear of needles, inflammation. And I'm a big believer in nocebo. If a patient is not convinced, you could have studies have found you could have a 20 to 30% efficacy of a nocebo effect. So if a treatment was going to be effective, they can reduce the effectiveness by like 20-30%. So if a patient is not convinced, I would argue don't do it. And I've told patients, a patient says, oh, I don't think this will work. And I tell them, I don't think we should do it because now you'll have a nocebo effect. And some people actually look it up and they say, oh, and the next visit, if they're not convinced, I don't do it. I had a 9-year-old patient last week. Kid has significant headaches, seen a neurologist. I saw, this was a third visit. did a bunch of self-care strategies, didn't work, started with physical therapy. She's had about 5-6 sessions. Now, last week I saw her, and the patient, you could see the patient is in discomfort, and most of her pain, the worst pain, is in the kind of masseter areas. And when I'm palpating it, she's like, this feels so good. Just how you guys were stretching, and I'm sure you felt some release. And I'm telling the mom, I'm like, do you think I could do trigger point injections? She's like, what are we injecting? I'm like, plain anesthetic. So mom was like, I think we are desperate. We should do it. Kid is a little afraid, and then kid was like, how much will it hurt? I'm like, it is like a flu shot. She's like, pinch me and tell me how much. I'm like, it doesn't work like that, but it hurts a little bit. So she was like, Mom was like, it hurts, but you're in pain a lot too. So the kid agrees. We do some trigger point injection, goes home, and I call the patient the next day. The mom was like, she feels a little better, but she was bleeding for like 3-4 hours. I'm like, so I injected some anesthetic. I injected about 0.3 to 0.4 ml local anesthetic, lidocaine. She was numb on the inside, and she just bit her cheek so much. I'm like, I'm sorry. I didn't think she would be that numb, but clearly she was. So lesson learned. Next time I'll do even less. I won't stop doing it, but nocebo effect. There's a bunch of papers on nocebo. I would strongly encourage you to read up on it. Any treatment you do, you can really improve your efficacy by kind of incorporating some of those principles. So what do these trigger point injections do? So nerve blocks or trigger point injections, they can kind of allow for physical therapy or rehabilitation, okay, or a dental treatment. And in chronic pain, it's neuromodulatory. Okay? They can downregulate the pain, and depending on the paper you're reading, there's a bunch of different theories why they work, although we really don't know. Okay? Supposedly, ropivacaine is one of the safer agents to use. Bupivacaine is similar, and then I use bupivacaine, lidocaine. Ropivacaine doesn't come as a multiple dose vial, so that's the main reason why I don't use it. This is a study which looked at comparing botulinum toxin versus bupivacaine for myofascial pain, and they looked at 18 small number size, 25 units versus half a cc, and it was a pretty well done study, and both treatments were effective, very similarly effective, and they looked at pain, function, and satisfaction, which I found it was interesting. Okay. Similar data with dry needling versus local anesthetic. Okay. And if you look at big picture, they inject, at least for temporomandibular disorders, masseter is the most common side, but some studies have looked at injecting medial pterygoid, lateral pterygoid, temporalis, and this is, we are talking botulinum toxin for temporomandibular disorders. So, and then this is, I found, in the scheme of things, I was extremely surprised that in current practice, botulinum toxin is used more than local anesthetics in kind of clinical practice. Plasma-rich protein, collagen has been done. There's one study looking at collagen. Okay. Even though there's lack of consistency, there's decent data that these agents work quite well. Okay, I'm going to switch to nerve blocks, which are, I feel, very similar to trigger point injections, except instead of targeting the muscle, we're targeting the nerves from an anatomical standpoint. From a mechanism standpoint, it may not be any different. Okay, so this was a study where they looked at different nerve blocks for headaches, and you see, they were all quite effective. So, which I thought was interesting. Okay, and even at 6 weeks, most of these nerve blocks, compared to this dark bar. So this is a 6-week follow-up, and you see most of these nerve blocks were effective. So even at 6 weeks, they keep on being effective. Occipital nerve blocks, one of an easy nerve block to do. And again, if you need slides, just email me and I'm happy to send you slides. Okay. Even in headache literature, now interventions are gaining some more press because they're effective. I was lucky early on in my career, I was exposed to injection therapies, and I employ them quite a fair bit because I feel it's another tool in your toolbox for injections. And these are some of the landmarks that are used for different nerve blocks. And one of the easiest nerve blocks you could do is the auriculotemporal nerve. It's quite superficial. Landmarks are easy. I use it for ear pain. I often use it for kind of a locked jaw because it innervates 60-70% of your temporomandibular joint. So even if they have disc displacement, if you give a proper block, it may reduce it. So this is not a really well-done study, but a pretty large study which looked at nerve blocks and quality of life, and quite effective, as you could see. Number of people found that it was effective to very effective, and that's been my personal experience. A lot of patients do well with injections. I believe certain people even get dependent on injections. Has happened to me a few times where they're like, when can I come back? I'm like, 1 month? Really? I have to go that long? But you said lidocaine is extremely safe. I'm like, yes, safe. It's not, the risk is not zero, and I want your central nervous system to change also. I want to give it a time. So I typically do once a month for like 3 to 4 months. Okay. Interestingly enough, there's actually a couple of studies which have looked at anxiety, depression being improved with just injection therapy. So, but I suspect this benefit is more to do with pain relief rather than injection specific. Okay. This was a retrospective analysis of topical versus injectable, and you could see injectables were definitely much better with regards to intensity of attacks, abortive medication use. So there's value in kind of doing that. Okay. Of course, topicals, as you could see, everybody likes topical because the treatment discomfort is minimal, but so adherence is definitely better with topical. Okay. All right. So I'll end up with a case. 65-year-old female, saw her in July of 2022, bilateral pain, classic temporomandibular disorder, okay? And this is kind of, I copy-pasted some of my history notes. I often use patient's words in my history. So the patient says, as the day goes on, it seems worse. I don't think it is grinding. She doesn't think she's grinding or clenching her teeth. It clicks and pops and makes different noises. It always feels tight, and I'm not clenching. I cannot seem to relax. Also has ear pain, ear squishing. She says she used to grind her teeth for a number of years. She has a mouth guard which does not fit. Definitely significant stress going on. Sleep is not so bad, but she does report a behavior where she's in front of a computer for a really long time before going to sleep. Poor daytime energy, reports no snoring or gasping for air. She doesn't fall asleep during the day. Okay. Medical history, lymphoma. She takes Lexapro and hormone replacement therapy. I always ask, do you exercise? She said, not enough, which is always a little bit of a problem. So my diagnosis was masticatory myalgia, insomnia. So I tell her, listen, I think we should do a mouth guard. We should do trigger point injection. And I gave her some stretchings to do, some warm compress. I asked her to take magnesium. So she decides she can't afford appliance. So we did some trigger point injections. So July, and I kind of lost her. I didn't see her for a little bit. And she got better just with trigger point injections, and apparently I gave her some NSAIDs. Okay? Sleep is now better. So, and when I asked her exercise, she's like, my husband is now, his fall is, he had a fracture or an injury, so he was not moving when I saw her in July, and now he's moving, so she's like, I'm quite active. So things, a little bit improvement from that perspective. So I said, let's do some trigger point injections. She was like, fine. So I did trigger point injections, and I injected about 0.5 ml at 4 spots. And I said, and she is very skinny. Her muscle is really not bulky. So small muscles, hence I didn't inject too many spots. I don't see her in a month, but I see her back, I want to say earlier this month, or earlier last month, April. She was like, I was great till January. So she had relief for November, December, January, about 2 months. And now the pain has gotten worse. Same exam. I asked her, do you think we can do a mouth guard? She was like, I'm not sure. Can we do the injections again? We did the injections. Oh, sorry. So, sorry, I had already prepared my slide, but I saw her about 3 weeks later. This time, the injections didn't help. She's like, I was good for like 4 hours. She's like, what happened? I was like, I don't know. Sometimes they just don't work. There might be different mechanism. I was like, can I take impressions? She was like, can you please do the injections? I was like, okay. So I did some injections. Pain went away. We took impressions. She's like, let me get back to you. If the pain comes back, I think we should do the mouth guard. So that's where we left about a few days ago. So it's never a linear sort of relation. So, and I think it's because the central nervous system is changing. How much time do we have?
About 4 minutes.
All right, 4 minutes. All right. I'll kind of stop with this. So I use dextrose combined with local anesthetics in my practice. I'm sure you've heard of prolotherapy. So although I'm not a big believer in prolotherapy, but I do believe dextrose, adding a little bit of dextrose has some value to it. The reason why I say we don't know if it's really, so the concept of prolotherapy is if you inject a sclerosing agent like dextrose, you can cause some inflammation, just a very mild inflammation which causes actually regeneration of the tissues in that area. Never been studied because I would suspect it would be easy to study, especially if it's a joint or a tendon, you inject a benign agent and flush that area out and collect the liquid back and see what kind of cells are there. If there's like pluripotent cells or regenerative cells, that's never been shown. And the whole concept of prolotherapy, is theoretical in nature, although there's some studies which show that it can definitely help disc displacement with reduction, without reduction, and joint mobility. So one day I just happened to kind of look at literature for dextrose and bupivacaine, and I found local anesthesiologists have been using dextrose for the longest time because apparently adding dextrose improves the sympathetic blockage, so has a better block by adding dextrose. So central nervous system is, we don't know a lot about it. There's a lot of things that we don't know about it. So that's, I found that it was interesting that adding a tiny amount of dextrose, you can have a better block, you can have improved joint movement. So I use that. Oh, this is my video. Oh, I guess I can't play the video. Never mind. All right. That's just a video showing kind of a masseter injection, something simple. All right. Yeah, injections, easy to treatment plan, but I always want to kind of pay attention to how fearful the patient is because some patients are extremely anxious. I've had a patient who kind of almost, I think she fainted when I told her, can we try injections? And I did not then. But all right, let's take a 5-minute.